to please take over the session.
Thanks, Dr. Venkatesh and the entire team of IMA JDN. I must really appreciate the efforts that you have taken into initiating this series of seminars where different specialists can give an idea to young MBBS doctors about the various specialties, because I think most people after MBBS are confused as to what specialty they should take and the line that they should proceed in. And this initiative from the IMA must be well appreciated. So I'll just share my slides.
Yes, sir. Please do.
Can you see my slides?
Yes, sir.
So thank you, Dr. Venkatesh, for that introduction. So I'm Dr. Sujith, working in Respiratory Medicine Department in CMC Vellore. I did both my MBBS and my postgraduate training from CMC. So during this talk, we'll go through some of the things that we'll go through is the history of respiratory medicine, how respiratory medicine has developed, some key milestones in respiratory medicine, the subspecialties in respiratory medicine, what are the various diseases that we cover, what are the procedures that we do, the lab investigations, and then we'll move on to what type of doctor are you? Are you suited for the field of respiratory medicine? And then finally, the options after you do MD or DNB in respiratory medicine. So respiratory medicine can be traced back to actually even till 2000 BC. The ancient Greek and Roman civilization, there's actually fossils that suggest that there was tuberculosis and allergies that existed even at that time. But the first concrete evidence that we have is from around 400 BC from our father of medicine, Hippocrates, from whom we have the Hippocratic Oath, who described various symptoms and signs in respiratory medicine. One common sign or popular sign that he described was the succussion splash, which we use to diagnose hydropneumothorax. Then around 200 AD, Galen, who is considered the father of experimental physiology, described the entire blood circulation and especially pulmonary circulation well before William Harvey did in 1628. And William Harvey expanded on his ideas about pulmonary circulation. Around 1800, Laennec, who many consider the father of am I audible?
Yes, sir.
Yeah. Okay. Yes, sir. The father of pulmonology, Laennec, again described many aspects of respiratory medicine, and he is the one who invented and patented the stethoscope. It was not until 1882 that the causative organism, that is Mycobacterium tuberculosis, was identified by Robert Koch. Like Dr. Hariharan mentioned, chest medicine was largely restricted to tuberculosis, and I'll explain why before we expanded into other chest diseases. And following that, it was Ehrlich, who was a student of Robert Koch, who gave the concept of anti-tubercular therapy or chemotherapy, with which there was options available for good treatment of tuberculosis. So here on the left, we have Laennec, who invented the stethoscope. Coincidentally, he actually died of tuberculosis in the year when he was just 45 years old. And on the right, we have Robert Koch, who identified the Mycobacterium tuberculosis organism. So it was not until the early to mid 1900s, with the concept of chemotherapy and anti-tubercular therapy, that the mortality from the treatment of TB began to decline. So till then, it was primarily isolating the patient into a sanatorium, and depending on the patient's natural defense mechanisms and the natural immune system to overcome tuberculosis with time. And you can see from this graph that after the mid 1900s only, with ATT, the mortality rate of TB began to decline. So what about respiratory medicine in India? So post-independence India, the leaders and the government of India realized that there was a high burden of disease, especially from infection, malaria, dengue, and they also understood that tuberculosis, which was called consumption at that time, because it consumed the person's breathing by eating up their lungs, had a very high mortality, especially with pulmonary TB. So the leaders recognized that there should be a post-MBBS designated course for tuberculosis, that is training MBBS doctors in the disease of tuberculosis, and that is the genesis of DTCD, that was Diploma in Tuberculosis and Chest Diseases. And a few years later, it was upgraded to the MD program, that is MD in Tuberculosis and Chest Diseases. And now it is popularly known as MD in Respiratory Medicine or MD in Pulmonary Medicine. So across the country, we have about 260 MD teaching hospitals, about 930 MD respiratory medicine seats per year. This is excluding DNB. There is also DNB pulmonary medicine and or respiratory medicine, and don't have the data for that. So quite a few seats every year from the All India Council. So what are the different aspects of respiratory medicine? So as you train, you will have clinical training, you'll have bedside clinical learning where you learn from the patient bedside. You also have teaching by your assistant professors and your consultants. Again, bedside teaching as well as seminars and journal clubs. Then you have procedures, which is a very important and integral part of the specialty of respiratory medicine. It is an intervention-based specialty, airway and pleural procedures. And then finally, you have research. So there are a lot of subspecialties, and you can go into research and specialize in any of those areas. So what are the diseases that we cover in, we look at the outpatient setting first. So the bread and butter diseases that we cover are allergies and airway diseases, primarily asthma and COPD, post-tubercular sequelae, especially bronchiectasis, that is irreversible dilatation of the airways. Then we have interstitial lung disease, both idiopathic as well as corrective tissue disease related ILD. Pleural effusions, they can be due to different etiologies, tuberculosis, malignant effusions. Pulmonary vascular diseases, what we commonly see is pulmonary embolism. Sleep disorders, one of the areas I'm interested in, and sleep medicine is something that has sort of boomed in the last 10 years, and the pulmonologist plays a very central role in diagnosing and treating sleep disorders, especially obstructive sleep apnea. Respiratory infections, both upper respiratory and lower respiratory infections, tuberculosis, pulmonary as well as extrapulmonary TB, occupational lung diseases, and diagnosing lung cancer. So if you, like I mentioned, the bulk of diseases that we see, or the bread and butter disease that we see, is airway diseases like asthma and COPD. Like, any specialty, if you take neurology, migraine would be a bread and butter disease. If you take medicine, it would be diabetes and hypertension. Similarly, we also have a bread and butter disease, that is airway diseases. The other diseases occupy fairly lesser amount in our OPD. What about the ward? What kind of patients present to the ward? So this is from my ward in the respiratory ward in CMC. So most patients, so acutely ill patients will come in with respiratory failure. Usually they'll be those who have come in with an exacerbation of airway diseases like asthma or COPD, or sometimes overlap syndromes, both asthma and COPD. And they'll come in mostly with type 2 failure, which is excess of carbon dioxide with a low pH. You also have OSA and OSA asthma overlap syndromes who come in with respiratory failure, and also ILD with respiratory failure. You also see patients with pleural effusion who have respiratory compromise. There's so much of fluid that patients come in breathless, chest pain. You'll have to intervene. You may have to put in a chest tube to relieve the pressure. Also, empyema or pus in the pleural cavity, which you have to relieve again with intervention. Worsening of interstitial lung disease or exacerbations of interstitial lung disease. Post-tubercular sequelae like bronchiectasis. Pulmonary embolism patients with usually present with type 1 respiratory failure, where there's a problem in oxygenation. Patients who have a large lung mass who have not been diagnosed, there is no histopathological diagnosis, come to us for symptomatic treatment as well as diagnosis. Iatrogenic pneumothorax, that is after a procedure, a CT guided biopsy or bronchoscopic biopsy, because of air leak, pneumothorax develops. We have to put in either, we have to use oxygen or we'll have to put in a chest tube. And then finally, some patients are admitted for sleep studies and BiPAP titrations, that is putting on the CPAP or the BiPAP mask and titrating the pressures required to relieve the apnea. So those are the diseases. So what are the lab-based teaching or lab-based investigations that we have? So we start with the pulmonary function lab, the PF lab, and this is the main test where we, the spirometry, where we identify if patients have a good lung function or not. If they don't have a good lung function, is it obstructive airway disease, or is it restrictive, or is it a combination of both? Lung volumes and diffusion capacities. 6-minute walk test to see if the patient is desaturating while walking or with exertion, and how far can he walk. Pheno and bronchoprovocation tests are to see if patients have eosinophilic inflammation of the airways and whether they'll respond to steroids. And finally, as part of the allergy workup, allergic skin testing for various allergens can be done. So that is a PF lab. Now moving on to pulmonary rehabilitation. So CPET or cardiopulmonary exercise testing is used for patients to assess anaerobic threshold and overall lung function with respect to cardiac function for patients who are to undergo a major surgery like a lung or a cardiac surgery, and also to diagnose patients who have unexplained breathlessness. Everything has been done, all the tests have been done, but you can't identify the cause. CPET is a test that we do, and you can see this gentleman on the treadmill where we are trying to get the anaerobic threshold. Pulmonary rehabilitation is where we train the patient to use his respiratory muscles and improve the respiratory muscle tone and strength, and that can compensate for the adequate lung function because of lung parenchymal loss because of diseases like COPD and interstitial lung disease. And we also have bronchial hygiene therapy, primarily for bronchiectasis. You would have seen chest physiotherapy, which is the simplest form of hygiene therapy. There are various mechanisms and devices that are used to clear the airways of mucus and mucus plugging, and that also forms a part of rehabilitation. So coming to sleep lab. So like I said, sleep medicine has sort of boomed in the last 1.5 to 2 decades, and primarily because of lifestyle diseases like hypertension and cardiac rhythm disorders, the obesity pandemic. So the primary tests that we use, or the gold standard for diagnosing sleep apnea, is polysomnography with a live video recording to see if patients are exhibiting any parasomnias or abnormal behaviors in the night, like sleepwalking, sleep talking, night terrors, they get up in the night screaming. So that is polysomnography. If you are interested only in looking at the respiratory events, there is limited channel sleep study. We're looking at the respiratory movements, oxygen saturation along with apnea. Then you have titration studies where you diagnose sleep apnea and then you need to put on the mask to see which pressure is eliminating the apnea and which pressure the oxygen level is maintained. The diseases we can diagnose are obstructive sleep apnea, central sleep apnea, or a mixed combination of both, hypersomnolence, parasomnias, and restless leg syndrome. So the treatment of the management of sleep medicine is a multi-department, needs multi-department cooperation and collaboration. Departments like neurology, general medicine, endocrinology, because they have a lot of patients with metabolic syndrome, ENT and dental because of structural causes that can be contributing to OSA, and psychiatry. We often forget mood disorders can be exaggerated if OSA, if sleep apnea is left untreated. So these are the various departments which we deal with while diagnosing and managing sleep apnea. So coming to procedures. So, anyone who asks me about respiratory medicine, joining respiratory medicine, one of the first things I tell them is you have to like doing procedures. If you do not like doing procedures, working with your hands, then don't even think about doing respiratory medicine, because to a large extent, it is a procedure-based and an intervention-based specialty. And here, one of my colleagues is doing bronchoscopy in the suite. So these are the various procedures that we have. So it is mostly airway related and pleural related. In airway, we have diagnostic as well as therapeutic. So the primary investigation is the bronchoscopy, where we go in through the nasal cavity or the oral cavity into the airway, into the bronchial tree, and based on the CT scan, we identify where the pathology is and take samples, both lavage as well as biopsy. Then we have EBUS, which is a more advanced procedure, combination of endobronchial ultrasound with bronchoscopy. So you're combining radiology with bronchoscopy. So it's a little more longer learning curve for EBUS. Then you have bronchoscopic guided procedures, which you'll do in theater with a rigid scope. You have to intubate the patient, debulking and stenting. Cardiologists are not the only one who put stents. So stents into the airway, where to keep the lumen of the airway intact after debulking. So that is another therapeutic airway procedure. Pleural procedures are both diagnostic and therapeutic. In diagnostic, we have simple thoracocentesis, where you are aspirating the fluid to see the character of the fluid and to send for microbiological testing and cytological analysis. You also have, if nothing yields in the fluid, you proceed with biopsy, either with medical thoracoscopy or ultrasound-guided pleural biopsy. Medical thoracoscopy was actually earlier done by the thoracic surgeons. We have taken over, and again, it's an invasive procedure where you have to go into the pleura and take pieces from the costal and diaphragmatic pleura. Then you have therapeutic procedures like pleurodesis. What is pleurodesis? After putting the chest tube, you put in a powder or a fluid which approximates the two layers of the pleura, that is the visceral and the parietal pleura, that prevents further reaccumulation of fluid in malignant effusions. And IPC is intrapleural catheter. Those patients who need long-term catheter, indwelling catheters, IPC is one way of doing it. So this is a Y stent. So the B diagram is the distal end, and C is the proximal end of the Y stent. And here you can see a patient who had left-sided effusion with the indwelling pleural catheter, IPC. There is significant resolution of the left-sided pleural effusion. So what type of doctor are you? Should you be considering respiratory medicine as a career choice? First of all, are you a clinician? Do you like dealing with patients? Are you willing to talk to patients? If the answer is no, then it is better to proceed away from respiratory medicine into a teaching specialty like the first year subjects or second year subjects, or into a research based specialty. If you are a clinician, if you like clinical work, then you have to decide whether you want to do something medical or surgical, or do you like both and you're not really sure, or you're confused as to which one you should proceed with. So this is where I was about 10 years ago, where I was trying to choose what was apt for me. So radiology is something I considered because I like doing procedures. So I thought I should go into radiology and then do interventional radiology. But for some reason, it didn't work out. And then I worked in the ICU, where I saw pulmonologists coming and doing bronchoscopies, chest tubes. And I thought, okay, this may be a specialty which I can do. And I pursued that. So if you are someone who likes mostly medical work, but also procedural aspect or the surgical aspect, then definitely respiratory medicine is a good career option. You want to be a specialist? No, I won't say it's an end specialty, because within the specialty there are multiple subspecialties. So, but at the end of 3 years of your training in MD respiratory medicine, you are a specialist, but you still will have to further specialize in an area of your interest, to become, get into that field and sort of establish yourself in that field. And work-life balance, during training it's tough, but I think post-training work-life balance is definitely better in an area like respiratory medicine. So what are the sub-specializations in respiratory medicine? Where the glamour is interventional pulmonology. You get to go into theater like surgeons. Intubation is done with rigid scopes, and you go in through the rigid scope with the flexible